Hi students, this is Dr. Swetha, your internal medicine educator from Medicoz community. So we have attempted to help you solve the NEET PG 2023 internal medicine questions today. So we have compiled a set of questions recalled by the students along with the options. So in case of any mistakes or omission, please do reach out to us on our official Instagram as well as our email. And I think as a whole, the NEET PG 2023 question was wholesome and tested various concepts from easy, moderate as well as very difficult concepts. But internal medicine as such, the questions were straightforward, but the options were a little tricky. So we have attempted to solve these questions and give you a guide. Use this as a stepping stone for your INICET and your next exam preparation, and make use of this video at the fullest. So hi students, so let's begin with the NEET PG Recall 2023. Without further ado, let's start with our first question. So the first question will be from the ECG with tall T waves. Which drug can cause such side effects? So there was an ECG given to all of you, and this ECG showed, if I'm not wrong, it showed tall T waves, and you were asked to identify which drug would cause these tall T waves, correct? So it showed tall T waves. Okay. So what do they mean by tall T waves? They mean to ask which drug can cause hyperkalemia. That is what they want to ask you. All right. So out of these drugs, you need to identify which is causing hyperkalemia. So it's very simple. So it's going to be spironolactone. All right. So this is going to be your answer. So what are the other drugs which could have confused you is ACE inhibitors, because they also cause hyperkalemia. ARBs can also cause hyperkalemia. Alright, so this was your first question. Moving on to the second question. So we'll solve the questions which have the least amount of controversy in them first. And then we'll move on to the questions where, the options and the question is slightly doubtful or poor recall is there. Alright. So the second question is, you have a mid-diastolic murmur with a prominent A wave in JVP. The A wave is prominent in JVP. So this is a straightforward question. A mid-diastolic murmur. A diastolic murmur causes is MS and TS both cause mid-diastolic murmur, but a prominent A wave in JVP is caused by tricuspid stenosis. So this is again a straightforward question. The answer is tricuspid stenosis. All right. So the third question is again a question on CVS. So you were asked to identify this particular murmur. This murmur, if you can see, it starts from S1 and goes up till S2. So it's a pan-systolic murmur. It's a PSM. So you need to know, students, what are the causes of PSM? MR, TR, VSD. Never forget MR, TR and VSD. Alright. So out of these three, what are the options that is available to us? So the answer is MR. Okay. So the answer is MR. So if you start solving questions with, a certain speed and logic, you will see that most of the answers come easily to you. Okay, so let's move ahead to our next question. Our next question is a patient with arm pain and ptosis. This is what you told me. A chronic smoker, if I might add, some of the students recalled that it had been mentioned that this patient was a chronic smoker with arm pain and ptosis and also Horner syndrome. So all this was mentioned and you were asked to identify the chest x-ray and the pathology in it. Alright, so what is this? So you can see the right upper lobe is somewhere involved. You were asked to identify what could be the likely cause. So the answer here again was something very straightforward. Pancoast tumor. Okay, so Pancoast tumor was the answer. Pancoast tumor causes, because of its impingement on the sympathetic chain, it can cause Horner syndrome, and also because the brachial plexus is close by, your CAT1 is close by, so you're getting your arm pain. All right. So next, quickly let's move to the next question. So this was again a very simple question. Chest pain radiating to the interscapular area. Okay, this itself should give you a clue to the diagnosis. There was a difference in BP in your left and right arm, and there was widening of mediastinum. All of this points towards aortic dissection. Okay, so chest pain can also be seen in pulmonary embolism, but the difference in BP is not explained. Takayasu arteritis explains difference in BP, but does not explain widening of mediastinum, or it does not explain the pain in the interscapular area. Okay, MI only explains pain and nothing else. So what fits everything together is aortic dissection. So the answer is aortic dissection. Okay. Okay. So let's now move to, I think this NEET PG medicine question paper had a lot of HIV and alcoholism based questions. So this one is based on alcoholic patient with confusion, ataxia, and nystagmus. And some students also recalled that it mentioned a sixth cranial nerve palsy. So what was the cause? The cause of it was simple Wernicke's encephalopathy. So the Wernicke's disease giving you the global confusion, ataxia, and the nystagmus. Simple? Okay, students. So moving on, we go to our next question. So now it starts, the questions further we discuss will be more conceptual. They will make you think more and won't be that straightforward. So let's pay attention and try to solve all these. Patient consuming only rice and pulses, presents with cheilitis and pallor. So the first question is, clue to this answer is there. Loss of vibration and proprioception. That means the sensory nerves are getting affected. And you also see an upper motor neuron type of weakness here. And then ankle reflex is absent. So the moment you see all this together, that there is some anemia and you have a neurological finding of this. So these together points towards vitamin B12 deficiency. And what do we see classically in vitamin B12 deficiency? Classically in vitamin B12, we see SACD, that is subacute combined degeneration of the spinal cord. So this is how you solve this clinical scenario question. Okay. So next, this again, I think most of you were confused as to what to mark. And students, this is very, very simple. A patient comes to you, however old, 60, 70-year-old, people told me it was an elderly female, had come with a presumptive or a suspected diagnosis of some hemorrhage. The CT found out was subarachnoid hemorrhage. So once you have an SAH in your CT, what do you do next? That is the question. So what do you do next if your CT is suggestive of SAH? You initially do an CT angio or conventional angio. Okay. As soon as you do a conventional angio, you will know why the SAH occurred. Was it aneurysmal or was it non-aneurysmal? Okay. So once you know whether it is aneurysmal or non-aneurysmal, you can decide what kind of surgical intervention this patient will require. And if it is aneurysmal, are there other aneurysms that have to be addressed? You can also decide based on the angiography findings. All right. So why not nimodipine? A lot of my students were asking why not nimodipine. See, nimodipine is given, must be given to all patients even if the BP is low. So BP is not the question here. We give nimodipine to prevent secondary ischemia. Okay, the vasospasm. To prevent that, we give nimodipine. So that should be instituted within 96 hours. That should be instituted within 96 hours. But the immediate or the next step management, the first thing that you have to address is you have to get an angio done after you diagnose an SAH on a plain CT, an NCCT. An NCCT shows you SAH, you have to immediately get an angio. Conventional angio used to be the gold standard, but since most places don't have this, we get a CT angio done. Alright. So CT angio will show you whether it's aneurysmal, non-aneurysm. Then you go ahead with a clipping or a coiling, whichever you decide. So all this has to be done within 72 hours. Okay. For best outcomes, you have to do it within 72 hours. So the priority is angio over nimodipine. So the answer here, please don't get confused. It is very, very simple. It is angio. Okay, it is angio. There is no confusion or arguments with respect to this. Okay, so nimodipine, usually the vasospasm sets in after 48 hours. Okay, that is why the guidelines say within 96 hours you should institute nimodipine, so that the peak of the vasospasm occurs 7 days. So that is when it peaks. So from 48 hours to 7 days, it can undergo secondary vasospasm, secondary ischemia. Okay. So simple answer is angiography. Okay, students. Okay, we move ahead with one more. There was a child, I think this was a pediatric question, with a high viral load, that is more than 2 into 10 to the power 5, was HBE antigen positive and HBS antigen positive. The answer to this question, see the recent guidelines also say a monotherapy, that is tenofovir. Okay, tenofovir was the answer to this question. Okay. Okay. So there was some cement factory worker and chronic smoker, and I think asbestos exposure is what they intended to tell you through this question. So the moment they say asbestos exposure, I don't think you need to have any confusion. The answer is going to be mesothelioma. Alright, there was poor recall for this question, but I think there is no confusion that the answer should be mesothelioma if an asbestos exposure, chronic smoker, and breathlessness was indicated, or some kind of lung involvement was indicated in this. Alright, okay. So there was one more, people were confused as to how to go ahead with the treatment in this case, where a chronic alcoholic presents with some sort of diarrhea, and on examination on ultrasound, we found out that he has 75 cc of a liver abscess, okay, probably amoebic liver abscess. So how to go ahead with treatment? So many people marked it to be PAIR. Please, PAIR, do not get confused. We don't do PAIR for this amoebic liver abscess. We do medical management, that is metronidazole if it is 75 ml. Okay, 75 cc we do only medical management. When it's beyond 100 cc is when we think of drainage. Okay, we do a pigtail and we drain it. I think you would have seen it in most of your surgical wards. You would have seen them placing pigtails and draining abscesses, but that is done only in cases of large liquefied ones. The small one, 75 cc, can be medically managed. Alright. So again, the answer is simple here. It is metronidazole. Do not confuse it with hydatid cyst. Okay. Lot of students, thought this was hydatid cyst and marked PAIR and came. So please don't, get confused with your hydatid cyst. Okay. So this is not, a point of argument at all. This is simply medical management. Okay. Fine. Next is there was a resident of Delhi coming with fever for 5 days. Platelet count was low, your WBC was low, and petechia was present. Simple, straightforward, dengue. All right. And I think even the coagulation profile was given. So the bleeding time was prolonged, but the clotting time was normal, as far as I remember from the recalls. So all of these, they all indicate, towards dengue. So you don't have to be confused. Some people thought it could be malaria. No, absolutely not. All of this indicates that this patient suffers from dengue. Okay. There was one more with a poor recall. I think rebound hypertension was asked, and you were asked to choose among the options. But since it's rebound hypertension and one of the options was clonidine withdrawal, I am sure that this is the answer. It is clonidine withdrawal. Rebound hypertension is seen in patients who have been on a long time on clonidine, and suddenly you stop clonidine, the BP is going to shoot up and bounce back to a higher state than it was to begin with. Okay. All right. So one more alcoholic man. So let's see. This alcoholic man has a painful swelling of the great toe. So uric acid is normal, but synovial fluid shows increased WBCs. There is no history of fever, trauma, or dysuria. What is the likely cause? So see, the moment they say there is no fever and there is no dysuria, the first thing you have to rule out is septic arthritis and reactive arthritis. They want you to go clinically here. So many patients, so many students came and told me, ma'am, this patient has increased WBCs and the uric acid is normal. So why not septic arthritis? See, septic arthritis typically has fever and usually involves the knee. Okay, so The great toe getting involved in just septic arthritis without fever is very, very unlikely. And what you also have to understand is in the acute phases of gout, an acute gouty attack, your uric acid levels in your blood might be normal, can be normal in lot of places. So this is your answer, gouty arthritis. Please don't get confused. So the moment they say there is no fever, there is no trauma or dysuria, they're immediately saying no pseudogout, no septic arthritis, and reactive arthritis. Okay. So gout is your answer for this question. Okay. So another very simple question. I think there was a child, a 3-year-old or a 3-month child with thinning of hair and history of raw egg consumption. I think it was a typical history. And I think there was no arguments here again. It was biotin deficiency. Okay. Fine. So one more pharmacology and medicine integration question was there, where the drug causing pulmonary fibrosis and hypothyroidism was asked. So which of the side effects of this drug? So the answer is amiodarone. Please remember, kids, that amiodarone can cause both hypo and hyperthyroidism. Okay. And it can also cause pulmonary fibrosis. So there are a lot of drugs that cause pulmonary fibrosis. Off the top of my head, what all can I recall? Let's see. Amiodarone can cause. Okay. Then your ergot alkaloids can cause. Then your methotrexate can cause. Okay. And then your busulfan can cause. So these are some of the drugs that can cause pulmonary fibrosis. So please remember, amiodarone can cause pulmonary fibrosis. Okay. So let's move ahead. So they had asked you what is the aim of using a tissue plasminogen activator in MI. So the aim is very simple. It is fibrinolysis or thrombolysis. I don't know which were the options given, but fibrinolysis was what everybody recalled. So fibrinolysis is the aim of administering TPA in myocardial infarction. All right. Okay. So a laborer with temperature of 105, pulse of 110 in summer was brought in an unresponsive state, and he was brought to the emergency department, and which is least likely to be found. Okay. So least likely is going to be sweating here. So this is a case of heat stroke. So there will be no sweating, least likely to be found. He will have hypotension. He already has tachycardia. From the question you've told me there is tachycardia. Red hot skin is possible, but sweating is the least likely. All right. Okay. So there's one more for hypercalcemia is found in which cancer? So hypercalcemia they want to ask is, I think there was also some large atypical cells given along with the question. So people were confused whether this is an anaplastic large cell carcinoma, and because it was a uh, what do you say, paraneoplastic syndrome, people were confused with small cell carcinoma. I think it's very clear. Everybody, please remember that paraneoplastic syndromes are more common with small cell carcinoma. Okay, this is very clear. But hypercalcemia is seen with squamous cell carcinoma. Okay, so it is very, very crystal clear. Squamous cell carcinoma, the moment you should think of hypercalcemia. Okay, so PTHRP. So if parathyroid related peptide is released, squamous cell carcinoma. So this is your answer. Okay. So next is this was again to test how good your concepts are. So it's a bronchial asthma patient presenting with atrial fibrillation and has also developed thyrotoxicosis. So what is the next line of treatment? I think the atrial fibrillation ECG was given. So the moment you read esmolol and propranolol, what are you supposed to think? You're supposed to think that the patient is asthmatic. So can I give beta blockers safely? Okay. So do I have other options? Yes, there is one more option, diltiazem, which is much safer and it will treat your atrial fibrillation. PTO is used to manage the thyrotoxic storm or the thyrotoxic crisis, but it won't take care of your atrial fibrillation. And you need to take care of your atrial fibrillation. You need to get the ventricular rate under control because then it can potentially cause stroke if left untreated and heart failure. Okay. So you need to treat it with diltiazem as per this question. Okay. So next is a very interesting question. So a patient on dialysis develops the following after a session of HD. So HD stands for hemodialysis, headache, nausea and vomiting. What is the treatment? So these are all features of dialysis disequilibrium syndrome. Okay, so these are all features of dialysis disequilibrium syndrome. So dialysis disequilibrium is managed with mannitol. Okay, this is usually seen after the first HD. It's not seen after every HD. This is usually seen after the first HD. Okay, so this is because of the sudden drop in osmolarity. Okay, so IV mannitol is given. Okay, fine. So elderly female staring at sky, bradykinesia, rigidity and tremors, and on autopsy, that is after death, there was an autopsy of the brain done. I think the hippocampus was showing Lewy body. Okay, so see, naturally, as soon as you see that, you have some EPS, extrapyramidal symptoms. Okay, some extrapyramidal symptoms are seen. So your prions and your Huntington's is ruled out. Very many students were confused between Alzheimer's and Parkinson's. So the best shot here would be your Parkinson's, or some of them recalled that there was a Parkinson plus given. But on a safer side, please mark Parkinson's, because the examiner's mindset, that is what you have to also understand. The examiner is leading you towards the answer. He's showing you that there is bradykinesia, rigidity and tremors. Okay, and he's telling you that there's Lewy body in the hippocampus. So all of this he's pointing it towards Parkinson's. If he was taking you towards Alzheimer's, he would keep describing the dementia. Yes, some of you also told me that there was visual hallucinations. Visual hallucinations can be seen in both Alzheimer's as well as Parkinson's. But these three, that is your bradykinesia, rigidity and tremors, are very typical of your Parkinsonism. So Parkinson's disease is your best bet in this case. So this should be marked as your answer. All right. Okay. So there was one more question of an HIV with CD4 count less than 150, homogeneous lung opacities with hepatosplenomegaly. And this, I think, was very typical of histoplasmosis. This was the answer. Histoplasmosis was your answer. I think the other answers were cryptococcosis, as far as I remember, cryptococcosis. And I think most of you got it right, because all of you were happy to see the picture also with hepatosplenomegaly and lung opacities. So good that you got your HIV answers right. Okay, this is a very interesting micro and medicine overlap. Encephalitis with bilateral temporal hemorrhagic involvement. Okay, so you have a patient, encephalitis is the picture, and you have a bilateral temporal hemorrhagic involvement. Okay, so temporal hemorrhage itself should tell you that the causative agent is herpes simplex virus. Okay, so the cryptococcosis will present with features of increased ICP. Okay, that instead of giving you temporal hemorrhagic involvement, they will tell you the ventricles are dilated and the intracranial pressure is increased. What about Mycobacterium tuberculosis? They will tell you there is basal exudates. Okay, they'll tell you there is basal exudates. Okay, and what about Streptococcus pneumoniae? They'll give you a typical picture of pyogenic meningitis. Okay, so these are some, typical presentations of these bacteria. So you should understand temporal hemorrhagic involvement is very typical of herpes simplex virus. All right, students. Okay. Okay, this is the 25th question. If you people are getting tired, this is your 25th question. So patient is having difficulty in expressing emotions with wife and also has rigidity and tremor. What is the diagnosis? Where is the localization? It's a very simple question of neuroanatomy and medicine together. This is basal ganglia. Okay, this is your answer. Yes, spinal cord involvement will show there is no involvement of emotions. Okay, the higher functions, higher mental functions will be normal. So no involvement of emotions. It will just either be sensory or sensory plus motor. Sensory plus motor. Okay. And what about cortex? See, cortex, there can be emotions, but along with emotions, you will also have some cranial nerve or your motor sensory involvement. Okay. And rigidity tremors are very typical of your basal ganglia. What do you see in cortex? If your cortex is involved, then you get spasticity, not your rigidity. You get spasticity more than rigidity. So this is what you have to understand. Okay? Okay, students. So this was a memory-based question. They had asked you to recall how to calculate GCS. So in this, there was this is what my students have recalled is eye-opening to pain, withdrawal from pain, and inappropriate words. Correct? So according to what you people have recalled, this should be a Glasgow Coma scale of 9. Okay. So let's see here. Eye-opening to pain was score number 2, E2. Okay. A verbal response of inappropriate words was there. So it is V3 and M4. That is a motor response. That is withdrawal from pain. That is M4. So ET, E2, V3, M4 is what I could uh, come to an answer after getting your people's recall. Okay, it's all dependent on your recall. Okay, so this was again a poorly recalled question. I don't know if someone can help me. You can put it and mail it to us or message us on Instagram. Could you tell me what was this question exactly? A patient was transfused 4 units of blood in 6 hours. Correct? So, after which the patient developed breathlessness and crepitus. What is the cause? So, I am missing some points in this question. Could you tell me whether any BP or anything else was mentioned? Why am I asking this? Is what are the blood transfusion reactions that we are scared of or we look out for in patients? First thing is coagulopathy. All right. Second thing is we look out for something known as tacho and trally. Okay. I'm not even sure whether these were there in the options. So if you can confirm and if you could tell us. So tacho and trally both occur within 6 hours. Okay. Tacho is transfusion associated circulatory overload. So both tacho and trally occur within 6 hours. But the difference between tacho and trally is trally has a normal BP, but you will have an increased RR. Okay, the tachycardia might be slight. Okay, but on the other hand, tacho has a very high BP. Okay, and the tachycardia will be too much. And we should also remember that trally is a non-cardiogenic pulmonary edema. It's a non-cardiogenic, so it has very poor response to diuretics. A very poor response to diuretics. But on the other hand, your tacho is a cardiogenic pulmonary edema. Okay, so your tacho is a cardiogenic pulmonary edema. So it has a very good response to diuretics. So this is why, but both of them occur within 6 hours. So one of your answers should be between tacho and trally. So you need to tell me more points if there's anything missing in this recall. So let me know either via Instagram or through our official mail. You can always drop by and give us feedback on these questions also. Okay. All right. Moving on, we have a patient who came to the emergency who took 100 tablets of aspirin. On ABG analysis, the pH showed metabolic acidosis 7.1. Bicarb was low. So what is the immediate management? So all of you, as soon as you read NAC, many of you have marked NAC and gum. But no students, the first or the immediate management should be alkalization of the urine by soda bicarb. That's right. You need to get his pH up. That should be your first priority. You need to alkalize his urine by giving soda bicarb. That is your answer. If they had asked antidote to aspirin, if that was the question, then NAC would have been the right answer. Okay. What is for glucagon? Where do we use glucagon? What is the antidote for it? All right. I think, you will have to keep revising your antidote lectures. Okay. I think some of you have not read Pharmac also that well, because a lot of you have gone wrong with your glucagon answer also. This glucagon is given when you have an overdose of beta blockers. Okay. When you have an overdose of beta blockers. All right. So the answer here to this question is going to be alkalization of urine by soda bicarb. Okay. So a patient is taking acute gout medications. Which drug works by inhibiting the synthesis of uric acid? So some of you have, as soon as you've seen acute gout, you've gone and marked diclofenac sodium. So that does not work like that. Okay. So if a patient is taking acute gout, there is a full stop. They're asking you which drug inhibits the synthesis. Okay. So you need to know the mechanism of action of all of this. So out of this, the answer for the inhibition of synthesis is allopurinol. This is your answer to this question. Okay. All right. So one more, an IT engineer with a history of hematemesis and melena has history of aspirin intake and occasional alcohol intake. Okay. So he is presenting with abdominal pain. What is the likely diagnosis? It is peptic ulcer disease. It is because of erosive gastritis due to aspirin intake. Okay. So I think around 4 years of aspirin intake was given, erosive gastritis causing PUD. See, if it was a malady state, they would have tell you some retching or vomiting. Okay. And if it was a variceal bleeding, again, they would have shown some signs of portal hypertension, or they would have stressed on alcohol, um, chronicity, and as well as presence of ascites or splenomegaly. All right. So with this chronic history of aspirin, you should think of peptic ulcer disease. Okay. An asthmatic patient on inhalational steroids, okay, showing features of oral candidiasis. What is the treatment? Treatment is clotrimazole. Okay. So that is why asthmatic patients, when we prescribe inhalational steroids for them, fluticasone or budesonide, we tell them to rinse their mouth as soon as they take the steroid inhalation. Okay. So this was again a very good question, very conceptual question. So this is your question 32. So a 10-year-old child post pituitary resection, his urine osmolarity is 100 and his serum sodium is 158. What is the management? Okay. So for this, this is a slightly difficult question. So normally we do pituitary resection through TSS, that is transsphenoidal hypophysectomy. That's how we do it. Okay. The surgery is transsphenoidal. It is TSS. So this transsphenoidal, what do we usually do is we take out the anterior pituitary. We take out the anterior pituitary. And we try to spare as much as possible. We try to spare the posterior pituitary. But despite all these efforts, we usually develop, 20% of them develop something known as transient, sorry, so 20% of them develop transient diabetes insipidus. Okay, so the key here is it is transient. Because it is transient, you don't need to treat it lifelong. So we give something known as DDABP, that is desmopressin. Okay, for 2 weeks only. We don't need to give it lifelong. Okay, and thiazide is for nephrogenic diabetes insipidus. This what we are talking of is central diabetes insipidus. It is not lifelong because this is transient. This is given from your Harrison. Okay. Okay. So there was an OP poisoning patient. He was treated with IV atropine and balm. He develops fever. What is the cause? So the cause here is likely to be IV atropine. The side effect of atropine is hypothermia. So it might be atropine-induced fever. The answer is atropine-induced fever. Okay. So there was one more of white hands in a patient working in machinery industry. What is the likely cause? So very simple again, it's long exposure to vibration. It's neither cement, arsenic, thinner or spirit. So people who are working with hammers or huge drill machines, they develop something known as secondary Raynaud's. Okay. So this is because of the constant vibration, there is mechanical damage. Okay. There is a mechanical wear and tear. Okay. This is why it's causing white hands. Okay. There was even very simple, question. Everybody would have been happy answering this. So diarrhea, the famous triad of triple D, diarrhea, dermatitis, and dementia. So this the vitamin implicated here would be niacin. Okay, all right. So there was one more that a drug inhibits both ACE, that is angiotensin converting enzyme, as well as nephrilysin. Okay, so it is an inhibitor of both. The answer would be omapatrilat. Okay, sacubitril is only a nephrilysin inhibitor, just nephrilysin. While on the other hand, losartan is only an angiotensin receptor blocker. That is why these two are combined. Okay, that is why these two are combined. But the answer here is a single drug is what they are asking. When they ask a single drug, then the answer is omapatrilat. Okay, all right. So your 37th question. Okay. So here again, there is some confusion here. So most of you have marked, I think, molluscum contagiosum for this question. Let's see the question first. HIV positive patient with CD4 count less than 100. He has a rash with pearly white nodules with central umbilication. So only till here most of you have recalled. Okay, the moment you have read central umbilication, you have gone and marked molluscum contagiosum. All right. But you need to read further. There is lung involvement. All right. And CB NAT is negative. What is the diagnosis? See, central umbilication white nodules are seen in both cryptococcosis as well as molluscum contagiosum. This is what you have to remember. This is given, if you want reference, this is seen in Harrison 21st edition. You can please go and review once. That molluscum contagiosum and cryptococcosis both have white nodules with central umbilication. Okay, but what molluscum contagiosum doesn't have is lung involvement. And CB NAT negativity would be never mentioned if molluscum was the answer. So here they are pointing it towards HIV with cryptococcosis. Okay, please remember, Gomori methanamine staining means it is zero wastage. And if they say that there is tuberculosis like picture, like miliary tuberculosis, or they say there is uterus involvement and disseminated and generalized lymphadenopathy, think of TB. And but when they're saying CB NAT is negative, but you have a lung involvement, please think of cryptococcosis. Okay, so this I think was a slightly difficult question, with most of you have very confidently marked it as molluscum contagiosum, but sorry to break the bubble. The answer here is HIV with cryptococcosis. This is the answer, students. Okay. So one more difficult question. A patient on chemotherapy developed decreased platelet count, that is thrombocytopenia. So to just increase the thrombocytopenia, what would you do to, what is the drug to be given to increase the platelet count? The answer is ocrelivkin. Okay. So this is an interleukin 11 stimulator. Right? So for thrombocytopenia, which is chemotherapy induced, the answer is ocrelivkin. Okay. A child with petechial rash, urine analysis shows owl's eye appearance. Causative agent, I think the moment you all read owl's eye appearance, you should jump and must jump to CMV, that is your cytomegalovirus. Okay, fine. So what is the antibiotics for prophylaxis in a patient undergoing cardiac surgery? Most of you have marked this right. It is cafazolin. Option A, cafazolin is the right answer. All right. So a patient is suspected of pulmonary tuberculosis, is AFB negative, but chest X-ray is suggestive of TB. What is the next line? CBNAT, CBNAT, CBNAT. For everything now, we do a CBNAT. Okay. Almost for all newly diagnosed pulmonary tuberculosis, whether AFB positive, negative, we tell them to undergo a CBNAT. Okay. The sweat chloride levels are measured in which disease? I think this was straightforward. Cystic fibrosis. Okay. And yes, coming to our last question. So this was almost a very poorly recalled question and option. I think a pediatric patient was given and you were asked the management of decay according to a specific guideline. This is what most of my students have recalled, that you want to manage a decay patient who is having severe dehydration. So here, my dear students, you have to tell me whether it was severe dehydration or was it shock, because there is a difference that if the patient is having very feeble pulse or no pulse, the recommended guideline is 20 ml per kg. But if it is only severe dehydration, then it is 10 ml per kg. Okay, so that is why I've written the answer here is 10 to 20 ml per kg per hour of IVF. And some people told me that some of the question had and some had after. All right. So it is usually after, followed by. So IV fluids first, okay, followed by, or afterwards you give the insulin. Okay. Because once you give IV fluids, there is a lot of hemodilution and water, because of the fluids that you give, there is expansion of volume and the glucose levels also tend to come down. So after that, we give infusion of insulin, 0.1 units per kg per hour of regular insulin is infused. So again, there is poor recall of this question and options. So I think with this question, we come to the end of this NEET 2023 PG recall. I look forward to hearing your feedback, your criticism, your appreciation. So I'll be looking forward to any of the feedbacks and help us recall and prepare more MCQ questions based on this pattern of exam. Right? So take care, students.